রিয়াদ আছো?
ম্যাম রিয়াদ ভাই নেটওয়ার্ক না থাকার কারণে ভাই একটু আনঅ্যাভেলেবল আছে নাকি। ম্যাম আমরা লাইভে চলে আসছি, আপনি স্টার্ট করতে পারেন।
থ্যাংক ইউ। Bismillahir Rahmanir Rahim. Alhamdulillah, we are going to start with a very essential topic for the medical sciences, ABC of X-ray. Here, we are going to be concerned with a chest X-ray, basically normal chest X-ray. We have to start with, and later on, we will go to the pathologist. Here you can see a chest X-ray, PA view. I think this is nothing new to anybody else in the medical science. And what we see really, the chest X-ray is component we have at the lung fields. Definitely we have the cardiac shadow, the vascular markings, the bony thorax, part of the shoulder girdle here, very small part of upper abdomen, and of course part of the root neck. Let's go details. And again in written forms, we can have a switch through the normal components of chest. Diagram includes hemidiaphragms, heart, lung, thoracic cage, part of upper abdomen, lower neck, and the shoulder girdles. The very important three things we have to go through before we enter in a chest X-ray to be interpreted are the three basic things we have to remain in our mind is whether this film is a PA film or AP film. Decide to be first, then the proper positioning and the exposure factors, and how it is important and why it is important we'll come to know. The first thing we have to decide that this film is really PA film or AP film, because the PA film we used to encounter in every way, but what about AP film and how it is important? Because we know that the PA films are taken in a position patient stand up, and most of the patients around are really stands up nicely and walks around in the chambers, and almost everywhere in the hospital patients are walking and standing. So PA films are very common for the clinicians to be gone through every day, and this is the thing we have our mind that all the patients, those who walks and stands, used to have a PA film to be supplied. But what about AP film? We know that the patients, those cannot stand up and those have critical illness, will not be able to stand up, will not be able to be seated enough, and we are going to have an AP film. So the important is, whenever you have got a film exposed in AP position and AP film, patients are really much ill and much to be concerned with acute conditions that a patient at that time cannot stand up or don't have the ability to even to be seated. So AP films are far, far important and far seeks the doctor's concentration multiple times more than a PA film really. So whenever we get a X-ray film exposed, whether it is PA or AP film, we must be decided earlier. Then what is the standard about the PA film? Because PA is very used to, we are very used to study X-ray with PA film. Let's go through first the common thing. The patient in this situation faces the film with chest presses over the film, the cassette film. The chin is directed upwards and the shoulders are internally rotated and backwards so that hands placed over the waist back to displace the scapulae from the lung fields. And the exposure is taken usually in standard conditions in full inspiration, and the film focus distance is 6 feet. This is really a description of a patient, practically a chest X-ray taken in a room in this setup, that the patient can be stand in a place to be exposed from the back, and the back of the patient is faced towards the extra tube and the chest is pressed over the cassette film. Most of the x-rays are taken in this way. And what about the this extra we have seen in the first film we have gone through? This is a PA film, standard PA film, and this PA film is displaying the inspiration at the height with the clavicles oblique, the ribs are directed oblique, and the cardiac dimension is near about or less than 50% of the internal thoracic dimension. So this is our PA film here seen, and and in the PA film, how we decide the clavicles are at the level of the fourth ribs posteriorly, and the dorsal spine is just seen through the cardiac shadow, and the ribs are more obliquely placed, and the hemidiaphragms are at anterior sixth and posterior 10th ribs. Anterior sixth and posterior 10th ribs, you can go through like this way. The anterior ends are like this: first rib, second rib, third rib, fourth, fifth, sixth, seventh. So these are the anterior ends of the ribs. You can read from the anterior aspect, and also you can go through the posterior aspect, as this is the posterior end of the first rib, this is the second, third, fourth, fifth, sixth, seven, and so on. So um, you can ask that, should I count the position or the situation from the anterior aspects of the ribs or the posterior aspect? What should we go for? About the zone division, you know that the upper zone, mid zone, and lower zones are divided by the lower ribs of the second, fourth, and sixth ribs, you know. But about the hemidiaphragms, I just advocate you that you should go from the posterior ends of the ribs, because from the lateral view in human, the posterior convexity of the hemidiaphragms, the height of the convexity is really nearer to the posterior half of the thoracic chest cavity rather than the mid or anterior aspect. So it's better you to go through the posterior ends study. In cases of study of the hemidiaphragms need not to be in same way as you describe about the lung pathologies when you describe it as the upper, mid, and lower zones. So it will be better if you go through the relation of the hemidiaphragms with the posterior ends of the leaves. Then, I have said earlier, and this is a film I think you don't like about because the total scenario is not at all very much known to us. There is the haziness seen around, multiple wires are running here and here. You know that really this is not a very clean cut and clear chest radiography. But why we are here? Because this is critically ill patients will need multiple wires around their bodies. And what about the scenario? The X-ray in this way is taken as the patient is lying on his or her chest, and the X-ray usually is taken by the portable radiograph where there is a limitation of the optimization of the exposure factors. Mostly they are fixed and you cannot change it so much. So you may have such a hazy film here. You see, you see that this film is describing a patient lying on his back, having multiple wires like ECG leads and JVP wires like that. So this is a very critically ill patients taken on a lying position. What we are seeing, we are here to describe the AP films. What about the clavicle? You see, the clavicle is seen to be cranially shifted, and you see that the ribs are horizontal more in this film rather than the previous film. You see these are obliquely placed and the clavicle is here. But what about this film? The clavicle is cranially shifted and the ribs are more horizontal. And if we very keenly see that the scapulae are seen in the chest cavities as the patient is lying on their back. So from this hazy film we can come to a PA film study to be read as a clavicles are more cranially shifted. The cardiac shadow is more magnified. That is, the dimension is in normal individual will be more than 50% because what happens in the AP film, the patient lies on his or her spine, and we know that the heart is the structure of anterior mediastinum gets magnified because it is getting more distant from the cassette film here when the patient lies on his or her back. So the cardiac magnification is a normal phenomena. So that even in a normal individual, a magnification of the cardiac dimension takes place, and the dimension is more than 50% in AP film.
আসসালামু
This
আলাইকুম ম্যাম।
fine.
ম্যাম একটু
Yeah,
আপনাকে ম্যাম আপনার মাইক্রোফোনটা যদি মুখের একদম কাছাকাছি হয়ে থাকে একটু দূরে নিলে মনে হয় বেটার, কজ একটু
দূরে নিতে
নয়েজি
হবে,
সাউন্ড আসছে।
আমাকে দূরে নিতে হবে।
মাইক্রোফোনটা মুখের একদম কাছাকাছি রাখলে একটা ওই যে ব্রেথের একটা সাউন্ডের ডিস্টারবেন্স হয়, একটু
এক্সট্রা
দূরে
সাউন্ড
রাখলে
হচ্ছে।
মনে হয়। জি ম্যাম।
ঠিক আছে বেটা, এখন ঠিক আছে?
জি ম্যাম,
এখন
এখন
ঠিক আছে?
অনেকখানি কম আছে। জি ম্যাম।
এটা কি ফ্যানটা কি অফ করে দিব তাহলে? সিলিং ফ্যান চলছে, আমি কি অফ করে দিব?
ম্যাম আপনি গরমের মধ্যে কিভাবে ক্লাস নেবেন? নো ম্যাম, কন্টিনিউ করুন, নো প্রবলেম।
এখন কি ঠিক আছে বাবা?
জি ম্যাম, এখন সাউন্ড
Okay?
নেই।
Oh, fine.
জি
Thank
ম্যাম,
you.
কন্টিনিউ।
Okay. So dorsal spine is more seen along its length because there is no cardiac shadow here to be disturbed for the visualization of the spine through the cardiac shadow. So the dorsal spine is more seen and the ribs are more horizontally placed. The scapulae are seen placed in the lung fields. I think this is, if you practice yourself by 2 or 3 films, that whether it is PA or AP film, you can come to be concluded that it is possible to be identified as a PA film or AP film. Then our next part of studying normal chest X-ray is the proper positioning. Each and every steps of studying an X-ray needs a proper positioning. Why it is important? I should describe those things earlier, that what is the outcome of proper positioning. What does disturbance happens with if you don't have a proper positioning of the patient? The rotated portion, that means whenever you have got no optimum positioning or the positioning is improper, it means that patient is not standing properly at a position of central positioning. He or she might be losing any half of the body to be away from the contact with the uh, X-ray film. How it is done? Whenever you stand for a PA film, you need to be pressed yourself with the cassette, film containing cassette. So if there is any disparity of the any half of the body to be pressed over the cassette, that is called the rotation of the patient. Or we used to say that the patient is rotated to the left or to the right. What happens with this rotation and how can we come to know that patient has got rotation? How we used to read that the positioning is all right. Come on, practical way. This chest X-ray has the dorsal spine is seen through the tracheal shadow herein. A normal chest X-ray PA film here, we used to measure the distance of the medial ends of the clavicle from a line drawn over the spines, dorsal spines in the upper chest, right? So we can make a line over here and make sure that the both clavicular medial ends are equidistant. It has got the same distance from the line drawn over the dorsal spine. I think this is very difficult for a patient to be stand in this way, and to get such a proper position film is very, I think this is not very simple. This is a very much calculated study, and that is that needs so much so technical application from the patient's side and also the technologist side. And a careful investment of both parties will allow to have such film without any error. So you may have error that there is some distance, at least some millimeter disparity will remain between the distances of the medial clavicular ends on both sides. And what is the thing happens when you have got rotated film? Has it got any value? Why should I go for that? And why should I need to make you understand? Because this positioning the minimal rotation means minimum disparity of the chest pressure over the film with create a rotation in the chest X-ray. Proper positioning in determined as central location of the trachea. And the central is really not that much carrying the sense of center. It is just off midline, like it is slightly off midline to the right side. And the equidistant clavicular ends will declare the patient proper positioning. The mistake will be like a whiter lung. The part which is internal, whenever there is rotation of the patient on any side, like patient is rotated to the left, you will get the clavicle to be more distant from the spine on the left side, and you will have a slightly blacker film on that half of the lung field, and you will get the mediastinum also to be displaced on the way the rotation goes on. So that if the patient has got a leftward rotation, the left lung field will have a blacker impression than the right one, and the mediastinum, usually 2/3 to the left of the midline, will be more to the left whenever the patient is rotated. It means even though the patient is normal, even though the film is taken with all optimum precaution, this rotation of the patient will produce a mistaken interpretation of the lung fields, that this whitish lung maybe there is any consolidation we cannot explain. That will be a mistake first for the beginners who are not radiologists. And of course, the mediastinal distortion towards the rotated side, that is producing another problem to everybody, because we know that there will be no negotiation about the mediastinal placement. The mediastinum must be at its optimum location in a normal individual. If there is any sort of mediastinal displacement, you cannot negotiate it. This is very, very important part of the X-ray study, that you must have your mediastinum in position. It means the cardiac shadow to be 1/3 to the right of the midline and 2/3 to the left of the midline, and the other vascular markings like the aortic knuckle to be left and the superior vena cava to be faded under the clavicle, right clavicle. If there is any distortion of the lung fields and in association with the cardiac dimension to be placed to the left, is a normal scenario if the patient has got a rotation to each side. Then what would be the another default? You must remember that patient has got a collapse in the right lung, okay, or lung base, and you have got technically fault X-ray to be rotated to the left. Mind it, the patient has got a right pulmonary collapse, not seen well in X-ray, and patient has got a leftward rotation. What you need to be interpreted very nicely, you have to have an interpretation that patient has got a right-sided collapse, so the mediastinum is usually shifted to the right, okay? But you have got a technically fault X-ray that patient has got a leftward rotation. So the leftward rotation will keep the mediastinum to the left. This is simple. You know that patient is rotated to the left and you will get the mediastinum to be rotated to the left. But if there is any collapse or any lesion that causes the right pulmonary collapse, the patient will have a midline mediastinum. Even there is a leftward rotation, you must be very critically encountered with this possibility that if there is any mistaken interpretation of the mediastinum, will cause a disaster and on both part of the patient and doctor. Okay, so you must know very well about the positioning factor of a chest X-ray PA film. You cannot negotiate any sort of mediastinal abnormality, and that is to be very critically understood by the clinician, by the radiologist. Okay, what about next? And finally we have the factor here, the exposure factor. The exposure factor is how important we have to know before the exposure factor to be decided. Now, what is the optimum X-ray exposure factors we have to know? Because everybody has got his or her own weight, own category of the body density, and the factors are going to be read in the X-ray film. So you must have a gross eye estimation about whatever the exposure factor is here, how does it uh, interacted with this very patient during exposure you made on X-ray plate. So what is the optimum exposure? The optimum exposure you have to study by few things like the vertebral bodies and the disc spaces are just seen at D8, D9 level through the heart. If these vertebral bodies are not at all seen, you can come to conclude that this X-ray has got a substandard exposure or underexposed film. And if the spine is much more seen than just seen, it will be just seen. When the spine is seen much more than usual, you have to conclude that this X-ray has got overexposure. And whatever the lung vascularity is well revealed up to the lateral aspect, and the amount of lateral chest wall soft tissues. How it is important, the amount of the soft tissues seen along the neck of the root over the clavicles, and some tissues will be seen on lateral chest walls of the lung fields. This is, I think, you have to very keenly see that yes, there is some amount of the soft tissue seen outside the thoracic bones. The thoracic soft tissues are to some extent present over the lateral chest wall and over the root of the nose, over the clavicles. It implies that yes, the exposure is at least up to mark. What happens whenever we have the overexposed or underexposed film? Does it matter or not? Why should I go through? And why should you need to understand it? You see, I think till I have described, I have gone through the part of the chest x-ray. You some part at least you will be able to explain some defaults also here. You see, this is an x-ray film. This X-ray film has got a thoracic dimension with the cardiac shadow to the left of the spine, and the chest film has got the vasculature seen at the center and also at the periphery. So, and this film, you know that it is blacker than the usual. Blacker. So this is overexposed film. This is under overexposed film. This blacker one, and this is an underexposed film. Underexposed film. This part has got the underexposed film whiter than the usual. So the overexposed film will reveal the miliary and early calcific nodules nicely, and the underexposed film reveal the hidden areas of the lungs, but miss bone and calcified lesions. So this is the most of the parts I hope I tried to cover about what you need to display the x-ray plate, how to read a normal chest x-ray. These are the things I have said to you, presented to you in a simple way. Later on, if you want to continue or not, I think today is enough to be load enough. You go through to rememorize all those things, and later on we will go through other normal things in normal chest radiography. Do you have any question I can have answered? Okay. Do you have any question?
আসসালামু আলাইকুম ম্যাম। ম্যাম কমেন্ট সেকশনে কোনো কোশ্চেন দেখছি না, আপনি চাইলে
Thank
এন্ড
you.
করে দিতে পারেন।
So let's us finish the session here today. Next one we'll talk about inshallah ta'ala. Thank you.
আসসালামু আলাইকুম ম্যাম।